Good day, my name is Imelda Williams. This presentation is a focus on the appendicular skeleton and the girdles, and I will focus on the normal radiographic appearances. The main textbook that I'm going to use here is Bontrager, and you will have electronic access to this book. There are also some useful websites that I've given here. The one is by Paceman, and the other one is by Junior Author Tiers, which focuses also on ABCs of interpreting an X-ray. So the main objective of this presentation is to make you aware that there's a set of radiographic evaluation criteria, and hopefully to increase your knowledge of how some of the basic physical principles affects the quality of the plain X-rays. So important that you do check each of the projections for adequacy. So when you're going to review the rest of the slides, you should be able to recognize the routine views for specific body areas, and then also to be able to identify the anatomical structures. Following that, to correctly identify the criteria for each of those views or projections, and then to appreciate the importance of each of the criteria in being able to confirm or exclude the abnormalities. So in terms of radiographic quality, there's 4 things I'm going to focus on. It's radiographic density, the radiographic contrast, resolution or sharpness, and magnification and distortion. Radiographic density refers to the degree of blackness on an image, and it will vary across the image. It is commonly associated with exposure selection. An image that is too dark is overexposed, and one that is too light is underexposed. So when we look at the image that we have here of the knee, we can see that it is too light, so that was underexposed. However, with digital radiography, there is no longer a clear correlation between exposure factors and radiographic density, as you can electronically manipulate the image. However, a too high or too low exposure can still result in an acceptable image quality. However, it must always be remembered that the patient will still be affected the same by the radiation exposure given at the time. Radiographic contrast is the difference in the density between one part of an image to another. So we're looking at the different tissue type or tissue thickness. So images with very high contrast, which has a short gray scale, have a black and white appearance. So it's very typical of the image marked A on this slide. So there's not enough of a range of radiographic density to represent all of the various tissue densities. Image with a low contrast, which has a long gray scale, has a flat gray appearance, and detail may become lost because of poor contrast resolution. So if we look at the image on case B, we can see that this is a low contrast image. So it's difficult to differentiate between the structures because some of them might now appear as if they have a similar density. The next point is resolution, or the sharpness of an image. So spatial resolution is the capacity of an image to discriminate between small objects when it's placed closely together. All structures on an image are surrounded by an area of unsharpness, and this is called the penumbra. The limiting factor of spatial resolution is the image display, and in particular, the pixel size. When there's motion while the exposure is being made, that will cause blurring of the radiographic image and then will result in motion unsharpness. When you compare image A to image B, you can see that the structures in image A is much more sharp and you can see it much more clearer. So the resolution is much better than that of image B. Magnification and distortion has an impact on the quality of the image. as a result of the relation that we have between the object to the image distance and the source to the image distance, so the source is normally the X-ray tube, there will be some degree of magnification, and this is unavoidable in radiography. If we look at the image on the left side, we can see that the magnification is larger if the SID is shorter, but if you increase the SID, then the magnification is less. Distortion is a result of unequal magnification. So there's some angulation. So if you have angulation of the object in relation to the film, or it could be angulation of the X-ray beam, and this can then result in either foreshortening or elongation. And the least distortion occurs at the center of the image. So it's important that your beam is central to the part that you want to see on the X-ray image. So here we can see that there is foreshortening of the image, and then on the right side that we have elongation of the image. I'm quickly going to take you through some of the projections that you need to know. So we're going to start with the digits, and here we have an AP view. We have, a PA view. In the middle we have a PA oblique and a lateral. So if you want to check if the positioning is okay, you should be able to see on the PA view that the IP joint spaces are nice and wide open, and that there is symmetry of the phalanges. You should also include some of the regional anatomy next to it so that you can identify which digit you're actually looking at. The metacarpal phalangeal joint should also be open. With the positioning of the fingers, there should be minimal soft tissue overlap, so the fingers should be spread a little bit. And then again, you want to look, this is now for the oblique, you want to look at asymmetry of phalanges, and then also include distal of the metacarpals. On the lateral view, the phalanges should be in profile with the interphalangeal spaces nicely open, and superimposition of the condyles, and again include some of the regional anatomy. So here we have the thumb, and the thumb was done with as an AP view, and then we have an oblique, and we have a lateral view. So for the AP view, you want to have the open interphalangeal joint and metacarpal joint spaces, again symmetry of the phalanges, and you need to see the base of the thumb, and then the density and contrast should show both, not just the bone, but also the soft tissue, and you need to show the adjacent connection with the carpal bone. On the lateral view, the phalanges will be in profile with the joint spaces nice and wide open, and again include some of the regional anatomy. Now moving on to the hand, and here we have a PA and an oblique view. So for the PA view, you want the hand needs to be nice and flat, so you don't want any rotation. The joint spaces should be open, your MCP and interphalangeal joints, and then normally the thumb will be in an oblique position and the wrist is in a PA position. For the oblique view, there should be a symmetry of the phalanges and metacarpals, and you will find some overlapping of the 3rd to 5th metacarpal heads, but there should still be minimal overlapping of the fingers, and the wrist will be oblique. Then on the lateral view of the hand, the bones will be superimposed, and then the thumb should be free of any superimposition. And the wrist is either lateral or slightly off the lateral view, and always include the distal radius and ulna as well. For our wrist, we need to have a PA view, oblique, and a lateral view. On our PA view, the distal radius and ulna should be shown with no rotation. And then on the oblique view, you want to show the scaphoid, but also the tubercle of the scaphoid, and then there will be some overlapping of the distal radioulnar joint. On the lateral view, You need to include the metacarpals and the distal third of the radius and ulnar, and there should be superimposition of the radius and the ulnar, and the lunate should be in profile. So with the forearm, you need to include the wrist as well as the elbow. The density and contrast should be such that you can see both the bone and the soft tissue. And on the lateral view, the elbow should be in a complete lateral projection as well as for the wrist, but on the full length of the radius and ulnar should be included. So with your long ones, always show both of the joints above and below. So the elbow, we have here an AP and a lateral. Again, when you include, with the AP view, you should show distal third of the humerus and the proximal third of the radius and ulnar. The olecranon process should be clearly seen, and the radial head should be in profile. On the lateral view, you need to include the distal third of the humerus and the proximal third of the radius and ulnar, and the olecranon process should be in profile, and the radial head should be in profile, and the humeral condyles should be superimposed. For the humerus then, again include the whole of the length of the humerus. So you want to show the connecting shoulder as well as the elbow joint. And the density and contrast should show both bone and soft tissue as well. On the lateral view, the elbow should be in a lateral position, and on the AP view, the elbow must be in an AP position. Moving on to the shoulder. So for the AP routine projection, include both ends of the clavicle, and then the humeral head will slightly overlap the glenoid fossa, and the greater tuberosity should be in profile. You should include approximately a third of the humerus, as well as the inferior angle of the scapula. Again, the density and contrast should show both bone and soft tissue. So the routine lateral view of the shoulder. So lateral half of the clavicle should be included. You should include a proximal third of the humerus, and the medial and lateral scapular border should be superimposed, and the humeral head is superimposed by the glenoid fossa, and the lateral thoracic should be included as well. There should be soft tissue visible between the scapula and the thoracic cage. So the Y shape is formed by the intersection of the scapular body, the acromion, and the coracoid process. Now moving to the lower limbs. So here we have the toes, and the projections here is an AP medial, and the lateral of the great toe. Again, you want to have the interphalangeal joint spaces nice and open, and there should be symmetry and separation of the phalanges and the metatarsal heads. And on the oblique, there should be minimal overlap of the adjacent toes. And on the lateral view of the big toe, the phalanges should be in profile, and the lesser toe should be retracted out of the way. And you should at least show the first metatarsal phalangeal joint as well. So looking at the foot, we have got our AP or DP view, oblique and lateral views. So on the AP view, again the metatarsal phalangeal joint spaces should be open, and the tarsal bones will overlap. You will have overlapping of the second to fifth metatarsals as well, but there should be no overlap between the first and the second metatarsal. On the oblique view, you should show the base of the fifth metatarsal with minimal overlap of the second to fifth metatarsal, and then you should be able to show the sinus tarsi. And on the lateral view, the metatarsals will be superimposed. You should include the distal phalanges. The entire calcaneus should also be shown in profile, and the ankle joint should be included. So now moving on to the ankle joint, and here we have AP, a medial or mortise view, and a lateral view. So on the AP view, the tibio-talar joint space should be nice and open, and the malleoli should be in profile. There will be some overlapping of the distal tibiofibular joint. The density on the images should again show both bone and soft tissue. Then on the oblique view or the mortise view, the talofibular joint space should now be nice and open, and the malleoli should be in profile, and the tip of the lateral malleola should be clear of the calcaneus. On the lateral view, the malleoli will be superimposed, and it's important that you see the talar dome in profile. And then on the lateral view as well of the ankle, you should always include the base of the fifth metatarsal. So for the lower leg, it's important that you include both the joints above and below, so include the knee as well as the ankle joints on both the AP and the lateral views. So you want the full length of the tib and fib, and on the AP view, the shafts of the tibia and fibula should have no superimposition. You should have the ankle joint on as well as the knee. On the lateral view, you should also have separation of the tibia and fibula, and remember your knee should be in a lateral position as well as the ankle. The knee has normally two views, so we have an AP and a lateral view. On the AP view, the patella should be superimposed, and it should be in the middle of the femur. The knee joint space should be nice and open, and you should be able to see the tibial spines as it's neatly separated. Your femoral condyle should also be in profile. You will find that the head of the fibula is partly obscured by the tibia. So on the AP view, you need to include the proximal third of the tib and fib as well as the proximal third of the distal femur. On the lateral view, again, you want to have the proximal third of the tib and fib and the distal third of the femur. Your patellofemoral joint space should be nice and open with the patella in profile. The femoral condyle should be superimposed, and the tibial tuberosity should be in profile. So it's not always possible when you do x-rays of the femur to include both the hip and the knee on the same projection. So sometimes you need to do an AP view with the hip down and one with the knee up. And then normally you decide on the lateral view which one, if there's any fractures or pathology, which one would be best shown. So here we have the lateral knee up. So on the AP view with the hip down, the hip should be in AP. On the images, you should be able to discern between the bone and soft tissue shadows, and you should also have the knee in profile on the view with the AP knee up. Then on the lateral view with the knee included, you should include the knee joint properly and as much of the femur as possible, and the knee should be in a true lateral position. Moving on to the pelvis. Again, you want to be able to see bone as well as soft tissue. There should be symmetry between the sacrum and the wings of both of the ilium. There should also be symmetry between the obturator foramen. The femoral neck should be seen with minimal distortion, so you want to see nice elongated necks. And then both the greater and the lesser trochanter should be seen in profile. You need to include the whole iliac crest on your pelvis and the proximal quarter of the femurs as well. So in summary, There's a number of variables related to the radiographic image that affects the appearances of what you will see in terms of the anatomical structures on those images. And that will include, for example, magnification as well as the exposure factors that's been set. It's important that you check the radiographic evaluation criteria on all of the projections, on all the views that you have for that specific case. In general, the radiographic evaluation criteria will include the complete radiographic anatomy and then also demonstration of the correct anatomical relationships and alignments in all of the views. So that will include PA views, oblique and lateral views, as well as the correct positioning of each of those projections. It's important also to think about the density of structures in relation to that around the structures. And then to consider whether there's anything else that could compromise the accuracy of the image interpretation. For example, if it's an elderly patient, the patient might not be able to breathe in as deep as they should, and that could affect how you actually see the lungs. The other important message is that the more you view radiographs, the more you will become more accurate in terms of identifying any of the pathology. Thank you.